Managing cardiovascular health after transplantation is an issue on long-term survivorship and life after transplantation of patients surviving more than 2 years. And today we will speak about cardiac and vascular late effect, the relationship with cardiovascular risk factors, and try to see what we can do with these patients. So what is the problem? The cause of death of patients surviving 5 years or longer after allogeneic transplantation is secondary cancer, recurrent disease, and at third place, cardiovascular complication. In autologous transplantation, recurrent disease, secondary cancer, but also at third place, cardiovascular disease, about 12–13%. The cumulative incidence of cardiac morbidity and mortality is continuously increasing when we compare to a general match population. Here, the patient for all evaluated parts. Here, cardiovascular death, heart failure, rhythm disorders, and vascular diseases. So I will start first with cardiac late effects and speak later about vascular complication. And I take first a non-transplanted cohort analysis, Hodgkin disease patients. They are very good examples for 3 reasons. First, usually they appear early. They have a high chance to get cured from the disease, and we have now a much longer follow-up time than what we have in stem cell transplantation. And in patients surviving Hodgkin disease, the standardized mortality ratio to what we expect for cardiac disease is increased, and the most important risk factors are mediastinal radiation, its dose, and the cumulative use of anthracycline. The type of cardiac morbidity can be very diverse. There is an excess risk of cardiac mortality in these Hodgkin patients surviving more than 5 years. The absolute risk is continuously increasing even more than 20 years after the diagnosis of the Hodgkin disease. And still in non-transplant cohort childhood cancer survivor, the cumulative incidence of cardiac heart failure in these childhood cancer patients is closely related with anthracycline with or without TBI. The red line is anthracycline alone, blue anthracycline and TBI, but when there is no anthracycline, the risk is much lower. So we come now to the cardiovascular complication after transplantation, and I show you data from autologous transplantation, but we will see it's very like the same in allogeneic transplantation. In this cohort of more than 1,000 patients, the cumulative incidence after transplantation is increasing. Even after 16 years, there is no plateau in this study reaching 9.1. A second very important, interesting point is female have more cardiac complication. It's not because the heart is weaker in female, but probably due to the different body composition. In physiologic manner, females have higher body fat for the same body surface area. And anthracycline do not go much in the fat cells, meaning that the other parts of the body have a relative overload of anthracycline. So anthracycline and stem cell transplantation. We know there is in chemotherapy-treated patients, there is a threshold that should not be overloaded in patient, because if patient receive more than a cumulative dose of 550, the risk of cardiac complication is very high. In transplant patient, it seems to decrease this threshold to 250 milligram per square meter, as shown here. Patient who did not receive anthracycline, this is a reference, and it's significant in patient receiving 250 milligram per square meter or more. But anthracycline is not the only risk factor. When there is a combination between high-dose anthracycline here, HDAC, or cardiovascular risk factors such as arterial hypertension and diabetes, it increases also the risk. Here is a situation where none of these is fulfilled. When there is just cardiovascular risk factors or high-dose RRC, then the relative risk is 3 to 6%. But when patient have a higher dose of anthracycline and arterial hypertension or diabetes, this increase very significantly the risk of later cardiac complications. Interestingly, and these are the study from Minnesota, they found that there could be a genetic susceptibility to anthracycline in a study where they evaluated 77 cases with congestive heart failure and had a match control with 178 patients transplanted but without cardiac disease. And the risk factor, as usual, gender, mediastinal radiation, arterial hypertension, but additionally a genetic variant. It's not a mutation, it's not an abnormality, it's just a polymorphism. And the genetic variants involved in these diseases are very understandable. The anthracycline metabolism, it can be changed by some variants, iron homeostasis, and we know iron overload is toxic for the heart, and also free radical generation can be changed. So if there is an unfavorable genetic variant, there is a higher risk of cardiac morbidity. But they made an interesting model. This is blood comparing sensitivity to specificity, and to describe what is the risk of what is the prognosis of a risk of cardiac complication. And the risk is highest when the curve is coming here. So we see the green curve are patients who had at the same time genetic susceptibility and clinical risk factor. So the combination of both leads to more cardiac morbidity. So what can we do? We know now the patient at risk. These are the patients with cumulative high anthracycline doses, with a radiation dose, and usually they are heavily pretreated patients for lymphoma or Hodgkin disease. There are some other subgroups they have not well evaluated. Patients with a high iron overload before transplantation, for instance, thalassemia patient transplanted for amyloidosis, or pre-existing comorbidity before transplantation. But interestingly, no difference between allogeneic and autologous transplantation. So what can we do for screening? Pre-transplant assessment should be done in each patient, the cumulative anthracycline doses and the dose of radiation therapy. And post-transplant, at least patients at risk should have regularly blood pressure assessment. And I think here also self-assessment. We can motivate the patient to assess his blood pressure at home. And if we are not sure, we can make a 24-hour monitoring. When there is arrhythmia, then electrocardiogram. And if there is a suspicion of cardiac involvement, then we should discuss the evaluation with the cardiologist. So what can we do? For prevention, it's rather depressing, because when patient came in a transplant center, usually they have already received their anthracycline dose and their mediastinal irradiation. So we cannot do. But nevertheless, there is a possibility. Indeed, patients who have received anthracycline, they have a heart injury, but clinically for a long time they can be asymptomatic, and we can try to protect the heart during as long as possible to postpone the moment of cardiac involvement. Using cardioprotective drugs, treat modifiable risk factors, arterial hypertension, diabetes, involve cardiologists in patient at risk, and again, we should involve the patient. Adherence to treatment is very important for arterial hypertension and diabetes, and I will come back to this point later. So the second part is vascular complication and cardiovascular risk factors. And again, I start with the Hodgkin group, which have not been transplanted. You see very young patient at diagnosis, 21 to 40. The cumulative incidence of a myocardial infarction is very increasing when you consider this young cohort of patients, and the general population, we would expect this. And you see in the first 10 years, it does not happen much, but after 20, 30, 35 years, it still continues to increase. And even patients younger than 20 have an increased risk. So what's in allogeneic transplantation? When we speak about vascular complication, we have not only coronary heart disease, also cerebrovascular disease or peripheral arterial disease. This is a cumulative incidence of patients here at transplantation, continuously increasing, not so much in the first year, but after 20, 25 years, it's increased to 22%. This, in fact, is not so surprising. With advancing age, a patient can make more vascular complication. But interestingly, here in our cohort, a patient with allogeneic transplantation had significantly more than autologous, and autologous in other studies showed not so different to a general population. And when we look the data according to the age at time of cardiovascular disease here, we see after allogeneic, the cardiovascular complication occurred between 40 and 60. This is unusual in a general population. We usually have it between 60 and 80. So there is a premature cause of death due to vascular complication. So what are the risk factors? The risk factors are first the standard cardiovascular risk factors we know in general. Here we see patient without the risk factor and with the risk factor, what was the risk for a cardiac event. All are involved: arterial hypertension, diabetes, dyslipidemia, overweight, and also the lifestyle, persisting smoking after transplantation and physical inactivity. But total body irradiation was not. Interestingly also, when there is a accumulation of cardiovascular risk factors, more than 50% of these risk factors, it's increasing fivefold the risk of a cardiovascular complication. So the cardiovascular risk factors are involved, but more cardiovascular risk factors make more cardiac events. Another very interesting study, because it shows another side, is again the study from Minnesota, the nested case control study with 63 patients with cardiovascular complication, the controls which were matched, as you see here, for gender, age, and so on. And they had, in multivariate analysis, 2 risk factors. A 9-fold increase for patients who received radiation therapy before transplantation, a mediastinal or neck radiotherapy. And a 5-fold increase for patients who had cardiovascular risk factors, but after transplantation. There was not an increased risk when the cardiovascular risk factor were before, and there was no increase when there was TBI. In this study, there was no difference between autologous and allogeneic. So there is some contradiction at first sight, and we have to explain why these studies show different results. First, to the radiation. Why mediastinal radiation is a risk factor and TBI not? Mediastinal radiation is given usually with 30 to 40 gray radiation dose. Total body radiation is 10, maximally 12 gray. So it does not mean that TBI does not play a role, but the other cardiovascular risk factors are so strong that statistically it does not come out. The second point, autologous versus allogeneic transplantation. We have a conflicting result. The study from City of Hope had involved in the autologous patient a lot of patients with lymphoma and Hodgkin, and 66% of the patients had mediastinal irradiation. In the study from Basel, we had only autologous transplantation with AML and myeloma without mediastinal radiation, meaning the difference is not due to autologous transplantation, but due to the mediastinal radiation. So it's clear cardiovascular risk factors make cardiac complications. This is also in a general population. Is the risk higher after transplantation? Again, a very nice study showing here hypertension, diabetes, dyslipidemia at baseline, meaning at time of transplantation, and 10 years later, the cumulative incidence. And we see, for instance, for hypertension, it starts at 22% because it was an older patient group. And after 10 years, it increased to 28%. This is not so surprising, could be more or less in a general population. After allogeneic, it was 11% because the patients were 10 years younger. But after 10 years, it increased to 40, meaning that these cardiovascular risk factors and also diabetes and dyslipidemia have a higher incidence after allogeneic and probably occur earlier after in life. So can we do something knowing that these cardiovascular risk factors are present? Here, an interesting study showing what could be the risk of coronary heart disease in black, cardiomyopathy in red, and stroke in blue when there is a cardiovascular risk factor such as overweight, smoking, diet, a bad diet, hypertension, dyslipidemia, and diabetes. And we see in depending these cardiovascular risk factors increase very much when they are present. So probably if we can treat this, the risk will be also respectively lower. So it seems to make sense to treat this patient. And interestingly also, the adherence to lifestyle recommendation, such as the correct weight, not smoking, a good diet, and physical, this should be inactivity, lead to a higher, not cardiovascular event, but risk factors, arterial hypertension in red, dyslipidemia in blue, and diabetes in green, meaning that if we can have a good lifestyle in this patient, this could lead to a decrease of these cardiovascular risk factors. So we can do something. So I showed you the risk of cardiovascular complication is higher, cardiovascular risk factors is higher, but why the cardiovascular risk factors are higher? It's not absolutely clear, but probably it's multifactorial. Hormonal deficiency after transplantation, hypogonadism, growth hormone deficiency, hypothyroidism, endothelial dysfunction because of irradiation, leading to insulin resistance. I will come back here. Here you have two populations, those with a metabolic syndrome, which is a syndrome with all risk factors involved. And here, normal insulin metabolism. We see patients who have a growth hormone insufficiency have more often a metabolic syndrome. So growth hormone deficiency could be involved. And what's about the insulin sensitivity according to treatment? Patients who have treated with chemotherapy, with or without cranial irradiation, have a normal sensitivity. This is not insensitivity, but sensitivity. When patients receive chemotherapy with bone marrow transplantation and total body irradiation, the sensitivity is increasing. So this is insulin resistance. What can we tell about body composition and body mass index? Most of us measure at the center body mass index, but maybe it's not very convenient because a normal body mass index does not exclude an abnormal body composition. In geriatric patients, you know this very well, this is the sarcopenia. And what happens also in transplantation patients with GVHD, they have a loss of muscle mass and an increase of visceral fats. And why this is worse? Because in adipose tissue, the insulin receptors are less potent than in myocyte receptors. And since they are increased and the myocytes are decreased, this leads to a glucose clearance decrease and an insulin resistance, leading to diabetes and metabolic syndrome. So the metabolic syndrome is increased after transplantation. In pediatric patients, 52 have an hyperinsulinemia and they're in controls. In adult patients, 34 long-term survivors have a metabolic syndrome and only 15 in control population. And it seems that insulin resistance could be a very important part, and we do not yet know what is the role of the body composition. So what can we do for these patients? The patient at risk, I think, all allogeneic transplantation. I did not include those with reduced intensity conditioning. And in autologous transplantation, those with radiation exposure. When to screen before transplantation and very early after transplantation, at 1 year. We should not think that we should wait, stop immunosuppressive treatment, and then everything will go better. It's not the case. And then we should make yearly control, which is more than in a general population. What should we screen? Blood pressure, I always discussed, lipid profile, screen for glucose intolerance, body weight and body composition, not only body mass index, and also screen for the lifestyle of the patient before, but mainly after transplantation. And what can we do? I will not go into detail of the treatment, but just give some remark. Start early to treat. Most centers 10 years ago waited 5-10 years because they thought it will all come normal again. This is not the case. And patient after allogeneic transplantation or mediastinal radiation should be considered as high-risk patient and not like a general population according to the Framingham score. Statin is still a good treatment for dyslipidemia, but we have to consider interference with cyclosporine. When we give cyclosporine statin increases very much. And the toxic effect of statin is due mainly with hepatic toxicity and muscle toxicity. To the treatment also, we should consider the counseling of the patient, healthy life diet, no smoking, regular physical activity, and body weight, and also the adherence to treatment. This seems trivial, but probably you know from the daily work, there are many reasons to not make a treatment for cardiovascular risk factors. In a general population, usually treatment for dyslipidemia after 1 year, 1/3 of the patient has stopped the treatment. Why it's so difficult? First, cardiovascular risk factors do not make symptoms. Why should I take a treatment? And this is a treatment that should go lifelong. And after transplantation, patient had received so many treatments, so they are not willing to take it more. But there are other factors, demographic factors, patient understanding. We have to explain why this is. Healthcare provider, the way we give the information and the way the interrelationship between the patient and the healthcare provider, but also cost can play a role, or the complexity of the regimen. I come to my last slide. We have seen the clinical event is a cardiac or vascular disease. However, there is a long time between stem cell transplantation and the clinical event, 10, 20, or 30 years. But the whole story starts at birth with the familial risk factors. We have seen genetic factors. What patient can do before they know they have the disease, the lifestyle adherence before the treatment. This is a general concern. Then comes the primary disease and the comorbidity with radiation and chemotherapy. Comes the conditioning and GVHD, and all this leads to vascular endothelial lesions and leads to de novo cardiovascular risk factors. If these are present, the premature arteriosclerotic process will occur and people will make earlier myocardial infarction, cerebrovascular insult. And the only way to reduce this is to intervene early, intensively in the treatment of cardiovascular risk factors and ask the patient to have lifestyle adherence. Thank you very much for your attention.
I think we have time for a couple questions. So I have a question. So when you start screening them post-transplant, what is your screening tool that you would utilize? For cardiac post-transplant, you start at 1 year post?
Sorry, I did not, acoustically, I did not understand well.
So a patient is 1 year post-transplant. They do have risk factors. What is your screening tool that you utilize?
We screen blood pressure, of course, and often it's not good. The blood pressure we take at the hospital is usually not a very good blood pressure. So we ask the patient to buy an instrument and to do it. And if this is not possible, we measure the 24-hour if we are in doubt. We measure the lipids, triglyceride, HDL cholesterol and LDL cholesterol, and start very early with the treatment. The first step will be lifestyle adherence, but already after 3 months, we should control it, patient without food in this morning, and if it's still increased, then we should start with statin. Diabetes, of course, we should screen by glucose and glucose tolerance tests. These are the 3 things we go systematically through.
What if they have a pre-existing cardiovascular?
Yeah, the question was what is with pre-existing cardiovascular problem. First, we involve the cardiologist. We maybe adapt the conditioning, but of course, we have to realize patient can make late complication only if they survives the first period. So the first aim is to get rid of the malignant disease. But after we can maybe adapt our conditioning and the treatment. And we discuss very early the protective drugs, even if there is no hypertension with beta blockers and so on.